Congreso Nacional de Ortopedia de la Ciudad de México, 2022. El Dr. Ronald A. Navarro se graduó en la Facultad de Medicina de la Universidad de Illinois en Peoria y realizó su residencia en ortopedia en el Centro Médico Harvard de la UCLA, con postresidencia en la Universidad de Pittsburgh en cirugía de hombro, medicina deportiva y artroscopia. Es Fellow en the American Orthopedic Association y en the American Academy of Orthopedic Surgeons. Es jefe regional de cirugía ortopédica en un plan sin fines de lucro en el sur de California, donde ayuda a administrar los servicios ortopédicos desde Santa Bárbara hasta San Diego, con 13 jefes de centros médicos en colaboración con más de 200 cirujanos ortopédicos. Además, es participante activo de múltiples asociaciones y academias de la especialidad y de organizaciones voluntarias. Cuenta con una amplia colección de publicaciones relacionadas con la artroplastia, una parte de las cuales pueden ser consultadas desde la red LinkedIn. El Dr. Navarro hablará sobre What to do after my bankart failed.
Hello, I am Dr. Ronald Navarro from Kaiser Permanente in Southern California. I'd like to thank the organizers of the Congreso Nacional de Ortopedia in Mexico City for the kind invitation to provide information around the topics that I will cover today. Hello, I'd like to share with you our thoughts on what to do after my bankart failed. I'd like to thank my medical student, Jacob Garamani, for his kind assistance. And once again, thanks for the kind invitation to this wonderful Congress. We have no pertinent disclosures, and they are seen in the AAOS disclosures. The concept of failed bankart repair has been covered in a wonderful review article showing that bankart repair can fail in 6 to 30%. Factors attributing to failure include trauma, poor technique, glenoid and humeral bone loss, hyperlaxity, failure to identify other rare shoulder pathologies as well. The failure rates in instability recurrence post-revision arthroscopic labral repair with contemporary anchor-based techniques are 6 to 27%, and the failure rates of instability and recurrence post-revision with open stabilization are much lower at 0 to 11.5%. The failure rates and instability recurrence after Latarjet are 0 to 14%. The reasons for the difficulties with instability, recurrent instability, are once again multifactorial and include recurrent trauma, sufficient energy leading to a repeat dislocation, contact or collision athletics, a poor surgical technique, including anchor placement, which is not consistent with good results, and errors in diagnosis in such that there is a failure to discern larger degrees of bone loss on both the glenoid and humeral side. Also, undiagnosed slap tears and multi-directional instability, including hyperlaxity, can play a part, as well as inadequate rehabilitation. In diagnosing recurrent instability, the concepts around pain, subluxation in bed, other sports leading to a continued mechanism, and a short time from index surgery to getting back to sport and vigorous activity can also lead to recurrent instability. X-rays can show glenoid and humeral defects, and MRI can show same. Intra-articular gadolinium injection can also help with visualization before the MRI to provide greater understanding. CT can quantify, or CAT scan can quantify Hill-Sachs lesions, and on the right you see the imagery on how to determine on-track and off-track lesions, as well as the concepts of the inverted pair are in circles. And you can see this other image that I just provided shows a larger Hill-Sachs lesion to help with that quantification. Non-surgical management of this problem can be started with physical therapy. This is a limited role and is usually not successful. The patient has recurrent dislocations. In patients who have MDI or who are hyperlax, that may be the type of population who you'd consider for continued non-surgical management because of the poor results in some of the hyperlax patients. And patients who have voluntary instability would also be considered for non-surgical management and continued rehab. In terms of just something to remember, an open bankart repair or an open capsule labral repair is very helpful. And in a review article showed Rowe reported a failure rate of 3 to 9%, and Faber et al. Showed in 50 patients greater than 20 years an instability recurrence of just 16%, whereas arthroscopic bankarts have much higher instability rates. So the open bankart, to avoid this whole problem, is something that should be considered and should not become a lost art. This is a review of the arthroscopic treatments that have been documented in the literature after a failed bankart, and you can look and see that a revision arthroscopic surgery after a failed arthroscopic bankart has failure rates from 27% down to 5 or 6%, but it still shows that there is some recurrence. How about remplissage and its role in arthroscopic bankart failure and treatment? 35 patients were looked at in this great study out of Louisiana by Dr. O'Brien and Dr. Savoie and others, and it showed that the patients who received a remplissage did have a lower revision rate, and the patients who had failure rate in revision cases was much higher. So although remplissage is helpful, it may not be the panacea for a treatment of a failed bankart repair. How about open bankart after a failed arthroscopic? Different than the slide I showed earlier. There's higher risk, less perform this, as I said earlier, and it may be a lost skill. But with an open bankart after a failed arthroscopic, you can titrate capsular tension. Hagel lesions and other lesions are easier to address. There's lower rates of subsequent instability and minimal recurrence in studies 0 to 11%, and potentially better return to sport. How about Latarjet or other big bone blocks, distal tibial osteochondral allografts for glenoid reconstruction? In this cadaveric study, it was shown that compared to reconstruction with distal tibial allograft and Latarjet bone block, comparing the two, reconstruction with distal tibial allograft had significantly higher glenohumeral contact areas and lower contact pressures and peak forces than the Latarjet. In looking at a small cadre of 3 patients with distiotibial allograft, this same group looked at this and showed that there's bony incorporation and remodeling without resorption in the patients, and early promising results with distiotibial allograft, which is shown to have great articular high conformity. How about Latarjet as a revision? Once again, just a clinical study showed in 52 patients, 96% of the patients with a Hill-Sachs lesion and 62% of the patients with glenoid bone loss lesions had good results. 49 of the shoulders were assessed after an average of 38 months, and 86 had a stable shoulder by using the Latarjet as a revision to failed arthroscopic bankart repair, and 14% had continued symptoms of instability. And this shows some of the other studies. So this is just a nice look at this Journal of AAOS article looking at treatment regimens and a summary management for failed bankart repair arthroscopically and what to do next. And in this, it says that physicians should design management protocols for failed primary arthroscopic bankart repair based on the assessment of patient-specific risk factors. In summary, there are a few options for this difficult revision issue. Recurrent instability is more common than we had hoped. Imaging is as helpful. Non-op and arthroscopic revision aren't as successful. Remplissage can be helpful. Open bankart is still a workhorse to successful outcome. Bony glenoid addition is helpful if needed, and base the treatment on patient-specific factors. Thank you very much.